Hello, everyone around the world. Welcome to the third 2020 IWMF Global Educational Webinar. I'm Carl Harrington. Like most of you, I'm a WM patient. I was diagnosed in 2006, and I'm also chair of the IWMF Board of Trustees. I really wish we could all be together in person, but this is the next best thing. It's my pleasure today to introduce Dr. Irene Ghobrial of the Dana-Farber Cancer Institute. It's going to help us all learn about how understanding precursors can help in finding a cure for WM. At the conclusion of Dr. Ghobrial's exciting lecture, we'll have question and answer sessions, so stay tuned. Thank you, and now over to you, Dr. Ghobrial.
Hello, my name is Irene Ghobrial, and I'm from Dana-Farber Cancer Institute. I think you know many people from Dana-Farber, Steve Trion and Jorge Castillo, and I've seen many of you before when I was seeing many patients with Waldenstrom, so it's wonderful to be back and to talk to you today about some of the efforts we're doing to try and prevent progression from IgM, Mgus, and asymptomatic Waldenstrom, like smoldering Waldenstrom, to symptomatic active disease. So before we go through that, let me just take you through the history of any cancer. Any patient who develops breast cancer, lung cancer, prostate cancer probably has many, many years where they had a small lesion, an early, something called precancerous lesion that was there, and they did not know about it for many years until they finally had symptoms and the disease was found. And in fact, in Waldenstrom, it's very similar. Many of you have asymptomatic disease. You were diagnosed with IgM Mgus or smoldering Waldenstrom, what we call asymptomatic Waldenstrom. And this is very similar in many blood cancers. So we see that in multiple myeloma, where we have the same thing in IgG Mgus. We see that in chronic lymphocytic leukemia, CLL. And we see that in many people who have something called CHIP mutations or stem cell mutations before they develop leukemia or other myeloid malignancies, something like MDS or leukemia. Now, how about IgM Mgus itself? What is my own risk of progression if I have IgM Mgus? The actual risk of progression is very, very small. In fact, it's about 1.5% per year. So if you see here the data from Dr. Kyle, and I trained with Bob Kyle, so I love talking about his data, you see here that IgM Mgus has a rate of progression of 1.5% per year. In fact, it's slightly higher than the IgG Mgus, so it's slightly faster to grow into Waldenstrom compared to IgG Mgus that goes to myeloma. However, the risk of death is very similar between them, and it's extremely delayed. This is not something that we need to worry about. So if you have Mgus, please do not worry. Your chances of progression in 10 years are 15%. And this is some of the data from that paper from Dr. Kyle in New England Journal of Medicine in 2018. And it shows you that most people who have an IgM Mgus will actually progress to Waldenstrom macroglobulinemia or non-Hodgkin's lymphoma, which in those days, those people were probably having Waldenstrom and it was just not diagnosed correctly. They call them lymphoma while it's actually Waldenstrom. Rarely, and it can still happen, that you can develop into multiple myeloma, IgM myeloma, or amyloidosis, which is again very important, and then occasionally CLL, the other disease that we were talking about, chronic lymphocytic leukemia. But in most cases, IgM goes to Waldenstrom macroglobulinemia. Now, if you say, well, I have a little bit more of the disease. I have 10% lymphocytes and plasma cells in my bone marrow. I have 20, 30, 40. Some of you even have 60, 70, 80% plasma cells and lymphocytes and plasma cells in their bone marrow, but they are asymptomatic. They don't have anemia. They don't have symptoms. They're doing great. We would call this smoldering or asymptomatic Waldenstrom. And your question is, what is my own risk of developing anemia, developing hyperviscosity, having big lymph nodes, having a big spleen? What is my risk of progression so that I meet the criteria of treatment? So we went back into Dana-Farber data and we looked from 1992 to 2014 at 1,936 people who have been seen at Dana-Farber who were diagnosed with IgM Mgus or smoldering Waldenstrom, which is the stage with 10% plasma cells and lymphocytes in the bone marrow. And we found of those people, 439 who met the very strict criteria of what we call asymptomatic Waldenstrom, excluding IgM Mgus. So a little bit more of a disease. What is your own risk of progression to symptomatic disease that requires treatment? And we found that indeed, many of those people developed anemia. The most common reason why you were treated was anemia, hyperviscosity, peripheral neuropathy, or hepatosplenomegaly, meaning the liver and spleen are big. And when we looked at factors that could be causing this, we found 4 factors were essential. The immunoglobulin M, IgM, if it was above 4,500, it showed that indeed you had a 60% chance of progressing within 2 years. So very high chance of progression. Bone marrow involvement, if it was more than 70%, you have a very high chance of progressing within 2 years. Again, 60% chance of progression. If your beta-2 microglobulin was above 4, you had also almost 65% chance of progression within 2 years. And if your albumin was low, below 3.5, again, a very high chance. And if you put all those 4 together, you suddenly see that there's a huge risk of progression of almost everyone having a 2-year risk of progression when they have one of those factors or multiple of those factors. And if you have none of those factors, your risk of progression is less than 9.3 years. So very long time to progression. Now, that's so important because today when you sit with your doctor and you have asymptomatic disease and you ask, what is my chance of progression? We did not know before that. So now you have this data and you know that you can look at those 4 factors. And in fact, we found that this was validated when we looked at the Mayo Clinic data, as well as data from the Greek group. So this data was confirmed in 2 larger cohort studies also. And we actually decided to look also at the MYD88 mutation, which many of you know about already, of course, that Dr. Trion has found. And we found that if you have a MYD88 mutation, you're actually doing much better. If you have wild type MYD88, so you do not have the mutation, that risk of progression was much, much higher compared to the other groups. Again, the numbers that we had with the MYD88 mutation were small, and hopefully we will have more data with that. But the best thing about that is we created this as a web-based program. So you can go on awmrisk.com, put your factors, and every time you see your doctor, you can actually see what is my own risk of progression. And you can calculate your risk at every single time. This is a dynamic, this is an interactive calculator. It's not a one-time point. We know that your disease can change, and we know that that risk calculator can change with you. And you can put on your 4 numbers and find out what is my own risk of progression to active disease, to disease that requires treatment. And then I would tell you that likely we need to change completely the way we think, and we don't wait for you to have active disease. If you have so many risk factors and you are almost going to progress in 2 years, let's think about something to prevent progression for you. So the other thing that I will talk to you about, and many of you know this very well, that Waldenstrom is actually very common in many families. In fact, when we look at the data, almost 30% of people have a familial history. Someone in your family had Waldenstrom or Mgus or myeloma, and you also developed it. And we had looked at that data back in 2016, and we found actually 2 genes that were very common. In fact, this was a family that had, dad had Waldenstrom, the one son and 1 daughter both had Waldenstrom, and the grandfather had Waldenstrom. So it kept going on in the family very strong. And we did genetic testing, something called germline sequencing, and we found specific genes that correlated strongly with familial Waldenstrom. And you can see this data here where we looked at the familial cases versus the non-familial cases with very specific genes, something called LAPTM5 and HLS1, HCLS1. Again, you don't have to know those, but knowing that familial cases are very important, and this could be potentially something that you inherit that increases your risk of having Waldenstrom. So with that in mind, I asked myself a big question. That's why I started a whole clinic that I'll talk to you about is, what are we waiting for? When you have this cancer already in your body and people tell you watch and wait, what we tell you in general is watch and wait until you have symptoms. It doesn't make sense to you, and it shouldn't make sense to us. And I can tell you that in any other cancer, let's take breast cancer, for example, a woman will get a mammogram, so we screen for it, and yet we don't screen for Waldenstrom. They found early stage breast cancer, and they remove it. They never tell the woman, you know what, you don't have any symptoms right now. Why don't you wait until you have fractures in your bones, until you have anemia, until you're falling apart, and then I treat you. Yet this is what we do every day with Waldenstrom. We don't screen for it, yet we know that many of you may be at high risk, especially family members. And when we find IgM, Mgus, or smoldering Waldenstrom, and when you have so many of those risk factors that you're almost going to develop Waldenstrom, we still tell you watch and wait until you have anemia, until you have hyperviscosity and neuropathy. And I think we need to change that completely. So how do we do that? We created a whole center called the Center for Prevention of Progression, or CPOP. And this is what I'm doing right now. I'm seeing a lot of patients. So if you have IgM, Mgus, if you have asymptomatic Waldenstrom, I would love to see you. And then, of course, Dr. Castillo is seeing all of the symptomatic people who are on active therapy. So we're sort of looking at the early prevention and then the treatment. And this clinic is for early precursor conditions of any blood cancer. So again, if you have early CLL, early Mgus of any other type, I'm more than happy to see you. And we created a whole program called P-Crowd. And P-Crowd is precursor crowdsourcing, but instead of crowdsourcing for money, we're crowdsourcing for patients. We want your information, and we want you to be part of that study. This is the first study that's what we call direct to patient, meaning we remove the physician, we remove anyone that can be preventing you from being part of the research. You can sign up on this anywhere you are in the world, actually, but mainly if you are in the US, anywhere in the United States, you can go on pcrowd.dana-farber.org, as you can see here in the slide, and you can sign up for it. And if you have Mgus or smoldering Waldenstrom or asymptomatic disease, you can be part of this wherever you are. And when you go see your doctor, we ask you to give us a little bit of your blood, or when you're doing a bone marrow, we ask you to give us a little bit of it. And we have 3,000 people who have been part of this work. And I can tell you it's only because of patients who are part of this research study that we can do many of the things we do right now. And then when we started that, and we found that it was amazing to find people online, to find people interested in their own research without us being, the physicians being part of the discussion, you can sign the consent online. We said, well, why are we not screening for it? If we can identify it early and we can make a difference by treating you early, why can't we screen for Mgus and the asymptomatic disease? And we started a whole program with Stand Up to Cancer called the PROMISE study. And the PROMISE study is basically the first screening study for Mgus and smoldering myeloma and Waldenstrom. And you can see here, I hope that you've received the brochure that we've sent ahead of time for the PROMISE study for Waldenstrom. And again, this is online. You can enroll on promisestudy.org, and you can be part of this if you have one of the criteria that we look for. So again, this is a QR code, so you can put your phone on it, and you can immediately get into our website. But this is the main consent form. Again, it's online. 3 questions, you answer them, you sign the consent on your own. You do not need a physician to be part of it, and we will help you through the program itself. So what is the eligibility? You have to be between age 40 and 75, and you are either of African descent, so Black American, or a first-degree relative of someone who has Mgus or Waldenstrom or amyloid or any of those blood cancers. Then you are at high risk. Just like I said, familial cases are much higher. We are looking for those familial cases to understand why you have this high risk of the disease. And why African Americans or Black Americans? It's because they have a much higher incidence of developing multiple myeloma. So unlike Waldenstrom, myeloma is more common in Black Americans. And what do? We test everyone, 30,000 individuals. We send your blood sample to Mayo Clinic. And not only we do serum protein electrophoresis and serum free light chain, we also do a very sensitive test called mass spectrometry. It's a brand new test, and I'll talk about that in a few slides, but it shows you in a much more sensitive way whether you have Mgus or not. And if you're negative, we send you an email. If you're positive, I call you, or someone from my team calls you, and we take you through the effort and research, and we can even see you virtually in my clinic. Whether you want to come, of course, in person or not, you don't have to. We do telemedicine right now all the time, or you can see a local doctor and we'll help you with that. And this is just the blood kits that we send to everyone, whether you're on P-Crowd or Promise, what we call them, the P-Crowders and the Promisers. We send you a kit. You can go to Quest Diagnostics or even to any of your blood your hematologist, your oncologist, and basically we draw some blood, and that's how we get the information. And here are some of our numbers nationwide, and I'd love to see more and more of those popping everywhere. As you can see here, the Midwest, we're not getting any of you guys to come on, sign up on it on promisestudy.org. Now, what are we doing with it? So I told you that we are screening now 30,000, not 50,000. And the reason for that is we're actually finding too many cases. And the hope was that we find 3,000 positive cases. And with that, we're asking big questions. Now that you have those big numbers, you ask big questions. What causes Waldenstrom? Why am I at risk? What's this germline sequencing, which is why is a family member having Waldenstrom and the other one having it too? What are the causes of progression? What makes me progress to active Waldenstrom when the other person who had it never developed it for years and years and years? Why am I the one who's developing it in 2 or 3 years into symptomatic disease? What is the race and obesity factor? Why Black Americans get myeloma? Why Ashkenazi Jews get Waldenstrom? Why, if I'm obese, would I get a higher risk? What is my immune status? I know that if I have autoimmune disease or if I have recurrent infections, if I get a lot of infections, my immune system is not working well. What is the effect of my immune system in getting me to progress that fast? And then can we develop therapies to prevent all of that? So these are all big questions. And for us to get 30,000 people, we hope that we can ask you all to be part of this. And we do the recruitment through many things. So you can see emails from us, virtual. We do webinars all the time to educate people. You're welcome to be part of that. And we do also interviews. As you can see here, Tom Brokaw had multiple myeloma, and we had an interview with him. Many of you may know Ken Anderson, of course, and many of you, of course, know Bob Kyle. And here's an interview that we had with him a few years ago. And we do a lot of on-the-ground work, especially for Black Americans, and trying to help recruit them and educate all of the information about the PROMISE study. Now, why is this important? And this is important for something called your genomics. You know very well MYD88 and CXCR4. You know what is a mutation and how it causes progression. And these are sort of those early events. This is a study that's in multiple myeloma, and we're hoping to do the same thing for Waldenstrom, where you see those tiny numbers of cancer cells, they get something else. They acquire second mutations, second hits, bad things that can happen to them as they grow more and more, as you can see here, until they get all the way to myeloma. So we're hoping to understand what causes that progression. And this is a study, again, in multiple myeloma that we just got out, and the hope, again, is we can do the same thing in Waldenstrom. We found differences in smoldering myeloma between people who progressed and people who did not progress. You can see here, these are the progressors, and these are the non-progressors, and we immediately found lots of dots here that were not here. These are mutations that are much more than MYD88 and CXCR4. And in that study, in smoldering myeloma, we found 3 changes in the genome, in the genes, that can predict for us if you will progress to myeloma or not. And I'm hoping that we do the same thing for Waldenstrom. We can tell you if you have MYD88 or CXCR4, but if we find that you have one more thing, if you find that you have a P53, then maybe that can help us understand better if your own cancer cells are going to progress faster to Waldenstrom or not. So not only we look at your beta-2, your bone marrow involvement, your IgM, but we dig deeper and look at your own cancer cells and what they do as a change. And then, of course, we look at the immune cells. And this is what we call the permissive microenvironment, meaning that your immune cells will allow the cancer cells to grow. They are basically the soldiers, the police force. And if they're not working very well, then they will allow the cancer cells to keep growing. And here I can show you that we did something also in multiple myeloma, taking Mgus or smoldering myeloma and active myeloma. And we found that even at the Mgus stage, even early on when you have Mgus, your immune system is not working exactly correct. So when people say Mgus is normal, you're going to be doing well, I actually would say that even in Mgus, your immune system does not work well. And many of you would tell me the same thing. You're asymptomatic, but I get recurrent infections, or I have neuropathy, or I have something else, or I have autoimmune disease. Your own body is telling you that your own immune system is already changing, even if you're Mgus. And that's what we're trying to discover in the PROMISE study and in the P-Crowd study. And for those, both of them, you are eligible to be part of it. And this is just the mass spectrometry data that I told you, extremely sensitive way to look at your IgM protein. And this is data from Mayo Clinic, where they compared in 37,000 people the old way of serum protein electrophoresis, your SPEP and your IgM level, to the new way, the mass fix, as they call it. And it shows you, especially in IgM, a much better way of detecting it. And in the PROMISE study, we thought that we will get only 6% of people. That's why we were hoping to accrue 50,000 people. And I can tell you now, we know that we have 12% of the patients that we screen are positive by mass spectrometry. So we doubled the number because we are much more sensitive in the detection. So this is just data from Mayo Clinic showing you that mass spectrometry can detect it early, can detect it even 10 years before you start getting the actual serum protein electrophoresis showing up, and it's much more sensitive, especially in IgM and IgA. And this is our own data. It went from 4.8% to 12.4% when we looked at it. The other thing that's nice about mass spectrometry is those people who may have something called amyloidosis, we can differentiate between the protein being glycosylated or not glycosylated. And that's important to know, because if you have amyloidosis, we would treat you in a very different way. If you have that, we would actually actively treat you very fast and not wait for you to progress. So that's another way to look at it with the mass spectrometry. Now, finally, COVID-19. We're all impacted by this, and that's why I'm not here with you in person. We're all in our own apartments or houses. And we started asking the question, what will happen to a patient who is asymptomatic, who has Mgus or Waldenstrom asymptomatic, and what is happening to their immune system? And will they do well with COVID-19 if they're infected, or will they do poorly and get hospitalized? And when we get the vaccines, hopefully we all get them soon, what is your response to it? Will you actually respond well? Will you have something called sustained immunity against COVID-19, or will you lose it and then you're also susceptible again to get COVID-19? And these are big questions, especially this year. We want to know if you're at risk, much higher risk than someone else, and not only that, but are you going to respond to the vaccine? So we developed a new study called IMPACT, Immune Profiling with Antibody-Based COVID-19. This will launch October 1st, so be on the lookout for it. And just like the other studies, it's online, it's available for you. You don't need anyone else to tell you about it. You go online and sign up for it. And this is just to make sure that we understand what happens with COVID-19 for the next year. And we test you for COVID-19 antibody and we give you back the information. So this is the website, so you'll be able to join us now. You can only sign up if you have been on PROMISE or P-Crowd. So please sign up for it. But for people who have symptomatic Waldenstrom who are on therapy already, we do not have this as part of this study. You can, of course, be part of other studies that are available in many centers, including Dana-Farber. So this is for the asymptomatic people, because we want to know if you are asymptomatic and you think that you have a normal immune system, what is your immune system and how will you respond to COVID-19? And so again, anyone who's a promiser or a P-Crowder can sign up to IMPACT. We will give you a COVID-19 antibody test by Quest Diagnostic, and then we will get the research sample from you to ask you big questions of what is your immune system, how does it respond, how will it react over the next year, and all of this information would be given back immediately every 3 months on the same portal that everyone is part of, and we will be informing you immediately for it. If you have not signed up already for PROMISE and P-Crowd, please sign up, and then you can immediately get access to IMPACT. And then this is, we're looking for at least 1,000 people, and we can sign up more and more people. So I know I speak very fast. Many of you who have known me before may know this already, but there are so many things we would love to do. We would love to understand who has Mgus, who has Waldenstrom, why are you getting it as a familial case? Why are you at risk? We want to stop this idea of watch and wait. I think we should really think of early intervention for people who are at risk. If you have a 2-year risk of progression that's very high, let's develop clinical trials to prevent progression. We have so many great drugs now, ibrutinib and many others. Let's really use them early to prevent progression. Let's not wait for you to have anemia and neuropathy and you fall apart and then I treat you. And maybe by doing that, not only we prevent the complications, but we can also improve survival, and no one should ever die from Waldenstrom. So with that, I'd like to thank you so much for being part of this, for allowing me to be part of it. And I hope you can contribute to the studies that we're doing. And I hope to see many of you in the CPOP clinic that we have. I work very closely with Steve Trion and many others to try to truly make a difference for our patients. Thank you.
Thank you, Dr. Ghobrial, for that brilliant presentation on how understanding precursors can help us reach a cure. We've got a lot of questions to cover today, and so we're going to get started right away. And thank you also for telling us about how we can join the studies you have going on, the IMPACT study, the PCROWD study, and the PROMISE study. So I'm going to start first with COVID-19, since that's in everybody's mind. Your new study called IMPACT to study COVID-19 in Mgus or smoldering WM patients sounds tremendously useful. How do I find the study? What's the URL, or how do I search for it?
Yeah, it's not launched yet. We're hoping to launch it actually in the next couple of weeks, so keep on the lookout. Only patients who signed up to PCROWD or PROMISE will be able to get to IMPACT, and we will be sending emails to everyone who's signed up. So I would encourage everyone, probably in the next couple of weeks, sign up to PCROWD, sign up to PROMISE, so that you're ready for IMPACT.
Right, and that information, everybody, is right in her slides, which you'll be able to go back and view at any time. Now, to participate in the IMPACT study, and I'm going to be reading these questions, so if I'm looking away, it's because I'm reading them. Is it essential to have blood drawn at a Quest lab? If most of us get our routine blood at our oncologist, can't they send tubes to Quest and avoid two separate blood draws?
It's a good question. The very first tube request is at Quest, because Quest is doing for us the antibody testing that we will give back to everyone. So that chain of information and making sure that the blood is drawn at Quest is very important. And then they also have our kits, although we will be sending kits to everyone. The subsequent blood draws at 3 months, 6 months, 9 months, and 1 year can be done with any local hematologist or oncologist.
That's great. Now, are there any costs involved in participating in IMPACT or PCROWD or PROMISE for that matter? And if there
Nothing.
are,
There is no.
will be covered by my insurance?
So zero cost, zero insurance in it. Actually, Quest Diagnostic has been wonderful enough that they are doing for us the COVID-19 antibody test for free. This is their own FDA-approved test, and we were going to put it as part of the announcement with a press release. But it's been such an amazing collaboration with them that they were willing to give it to us for free for everyone who signs up to the study.
That's wonderful news. I'm just going to switch to a different topic for a minute. We're always nervous about this. So is it safe for us to get a flu shot?
The answer is yes. Again, flu shots are important. COVID-19 is one of the viruses, but there are so many other infections happening, and we should always be careful with ourselves.
Okay, good. Now I'm going to switch over to talking about management of asymptomatic patients and the risk assessment tool and that sort of stuff. Now, you mentioned loving Dr. Kyle. Me too. Now, one article that he published showed that people with smoldering WM progressed to needing treatment at a rate of 12% a year for 5 years, and then it falls off a cliff to 2%. Are you attempting in your study to find those 60% of the people who need the treatment in next 5 years and get treatment to them, get them help sooner?
Yes. I mean, if you think about it, why do we have to wait until I have anemia, until I have hyperviscosity, until I have blurring of vision? None of that makes sense. It used to make sense in the old days when we had no therapy or bad therapy. Now we have amazing therapy for Waldenstrom. So early detection, early treatment would make a difference, not just for the survival, but also for just the quality of life, for not having to go through a problem with bleeding, a problem with neuropathy, and so on. So I would love to change that way of thinking, bringing treatment early, especially if it's non-toxic. And let's try to make sure that our patients are not having problems before they get treated. We can only do that with clinical trials. We can only do that by proving that indeed this is beneficial. But the concept itself is that early treatment always makes sense in our patients.
Okay, so you encourage asymptomatic patients to consult with you at your CPOP clinic at Dana-Farber. Do you do remote telemedicine, or is it necessary for us to travel to Boston to see you?
Yes, most of my consults are now virtual. They're all telemedicine. Occasionally, we do want to see patients here and there if we have to. Of course, examining you is an issue that we haven't resolved yet by telemedicine, although I've heard there are stethoscopes that you can have by telemedicine. But there will be some times where we say, okay, maybe we do need to see you if it's complicated. But most cases, not complicated, we're happy to see virtually.
Good. That's very reassuring. Most of us don't want to be traveling these days.
Yes.
Now, the next question is, I thought the idea behind watch and wait was created because of the side effects of early treatments for WM were higher risk than waiting. Now we have better, easier treatments with fewer side effects and deeper, long remissions, as you just said. Does that change your recommendation for all smoldering WMers or just those in the high risk category?
Yeah, I mean, again, Bob Kyle, and I said he's my mentor, has said we have to be careful that we don't overtreat and we do not cause harm, right? So there is that, and we need to figure it out. Who is the patient who truly will benefit from early treatment? Because if you're completely asymptomatic and you're not going to require therapy for another 10 years, we should not be treating you. We should not be giving you anything because every drug potentially has side effects. So again, being careful of who should be treated and with what treatment. And I would not treat as standard of care yet because we haven't proven that we can improve survival. We have to do clinical trials first to prove that.
So you're saying that you don't have a particular treatment that you recommend for these people?
No, I would not. The one thing to be careful is I did not recommend that you should be treated as an asymptomatic patient. I would recommend that you consider clinical trials and you consider first trying to be part of those studies to understand whether you are at risk or not for progressing to Waldenstrom.
Now, the new IWWM consensus guidelines for treating WM in the COVID-19 era says raise the bar on when symptoms warrant treatment. It says that watchful waiting should be the preferred strategy to avoid immunosuppression and COVID infections. What are your thoughts on this?
Yeah, again, this is, we are right now in the pandemic. We are right now in all of the problems. So I agree that we should be careful not to start thinking of treatment right now. But I'm thinking next year, hopefully, as we all hopefully emerge out of this craziness, we want to start thinking what's ahead. I'd love to, and again, I don't have active clinical trials right now for smoldering Waldenstrom, but I would love to launch that as our new area of investigation for everyone, really, to truly make a difference for our patients.
Okay, thank you. So how many people with WM do you treat at CPOP, and how many would you like to have?
Everyone. So again, the CPOP is for asymptomatic patients, not for Waldenstrom. We work very closely with Dr. Trion and Dr. Castillo. So if you have symptoms and if you need treatment, usually we refer you back to Dr. Castillo. We only see the IgM, Mgus, the asymptomatic Waldenstrom until we develop clinical trials, and we will probably develop those very closely with Dr. Castillo and Dr. Trion.
Now, can you have this tool for asymptomatic patients? Can you repeat the URL for that?
Oh boy, it's in my slides, but I'm sure I can find it. But if you look up the Waldenstrom calculator, I think, and then you will find it.
I think it's easy for all of you who are watching. Just look back at the slides. The URLs are not easy to say, and they're all in the slides. So just look there, because that was a continued question across a number of people. The risk assessment tool, let's talk about that for a minute. You said the 4 key risk factors for smoldering WMers were an IgM over 4,500, bone marrow infiltration greater than 70%, beta-2 microglobulin greater than 4, albumin less than 3.5. Is one of those more important? What's rated more heavily in your model?
Yeah. So we did actually, and this is one of the wonderful things, that this is not a yes or no answer. If my IgM is this number, then I'm a high risk or not. This is the old way of thinking, when we used to say, I'm carrying a card as a physician and I'll remember IgM 4,500 is the bad one. Now we have the technology. We can put your number, and the weighing depends on which one is more important, whether it was the percentage of bone marrow, it was the IgM. These took a little bit more weight than the other factors. But again, what we should do is not try to do it ourselves. Just put it into the calculator. It's available everywhere, online, on your phone. And you can change, the number changes every time you're seeing your doctor. So that's important, because this is a dynamic process. Waldenstrom is dynamic. It grows as we progress every year, every 6 months. We should not be using a number from a year ago or 2 years ago.
I think the questioner was asking, is one of those 4 factors more important than the others in the outcomes? Or are they all?
They're all the same, yes.
Okay. Now, I can relate to this question. I haven't had a bone marrow biopsy in years. Do I need a new one? And is there a proxy test that we can do instead of a bone marrow? Because those are ouchy. I heard there might be one. If so, would that work for your study?
Yeah, so we're doing on the P-Crowd study, we're doing blood samples on all our patients. And if you're smoldering Waldenstrom, it's every 3 to 6 months. And we are now developing something called liquid biopsy, meaning we can understand what happens in your bone marrow through your DNA in your blood. Either something called circulating free DNA, your cancer cells shed DNA into the blood and we can capture it and we can get all the information, or something else called circulating tumor cells. Again, these are research level for now, but we're really working hard to bring those as a clinically available test so that you can get a blood sample instead of a bone marrow biopsy and get all of the information.
But for the moment, we still would need the bone marrow biopsy?
Unfortunately, yes, every now and then.
Can you work faster on that?
Yes, I will.
Now, my oncologist, this is true for me personally, doesn't usually do a beta-2 microglobulin test every time. Should I ask for that?
Well, for the smoldering part, it was part of our information that we had. But again, talk to your doctor. I think it's one of the criteria that we use. It doesn't mean that it has to be done all the time.
There's nothing special that needs to be done to do that. You just have to run the test.
Correct.
Okay. I can ask him that the next time I do it. Now here's a question we have many people on this call from outside the US. So they live out, is this person, I live outside the US. How do I enter my numbers in your calculator? Because of course, international numbers are different.
That's a very good point. We should make sure, and I'll double check on the website, that it can switch between milligrams per deciliter or not. So that's a very good point. But otherwise, you can also switch it. It's very easy. Just re-enter the numbers and add the extra zeros depending on where you live.
We have that question a lot on IWMF Connect. Somebody said, my IgM's 36. And I say, well, mine's 3,600. And they go, people get confused very easily.
Yeah.
Let me go to the P-crowd study now for a minute. Early detection of amyloidosis is important in WM. You said that you were doing Ig light chain glycosylation analysis as part of the PROMISE study and informing subjects of the results. Are you also doing that in the P-crowd study?
So we just got a collaboration with Binding Site. We will be getting the machine very soon, and we will be doing mass spectrometry on all the samples of P-crowd. We're not there yet, but PROMISE, we already have it running as mass spectrometry. And of the first 1,500 we've done so far with Mayo Clinic, we had a lot of cases, not a lot, but a few cases with glycosylated protein, which then brings that point of, is this amyloidosis? Are we detecting it early? And it's such an important thing, you're right, because this is when early treatment can truly make a difference for amyloidosis.
Okay. So for the purposes of your studies, we're talking P-crowd now, how do you define asymptomatic Waldenstrom's? Does that include all the patients on WM?
Well, again, if you have had symptoms, meaning anemia, hyperviscosity, neuropathy, anything that required treatment, then you are not in the asymptomatic category. You are in the symptomatic or treated already. And again, there are so many studies. Dr. Trion, Dr. Castillo are doing so many studies in that area. What I've done is just refocus into the earlier setting of IgM, Mgus, and smoldering Waldenstrom. And we're complementary. We're basically taking that whole spectrum together.
But there's some gray areas with low-grade symptoms of fatigue or anemia, not severe enough yet to be treated. Are those in asymptomatic in your definition?
Yes, again, either or. We're all one team. So if you see me or you see Dr. Castillo, it doesn't matter.
Okay. Do you have a specific cutoff for anemia or for fatigue?
No.
Okay. Now, this is actually, some of you like this person. I'm a subject in your P-crowd study. It's incredibly smooth and easy to participate. Your staff are always helpful. Did you write this question?
Oh, that's wonderful. Can we talk after this?
What is keeping more asymptomatic WMers from joining the study? What do you think are the barriers for participation?
Yeah, and I'd like to maybe ask him back or her back this question. What is the barrier? I mean, I think a few things that we're doing, we're now relaunching the P-crowd website to give you back the information, to give back all of the studies that we're doing, even if it's every 3 months. We're thinking of webinars every month for only the P-crowders and the PROMISE patients so that they have this access. It becomes a community so that people have access to us. We're thinking of how can we inform people about P-crowd. Maybe not everyone knows about it, so improving our social media. But if you have any other ideas of how we can improve on our work and how to make this truly a community for patients, it is truly by patients for patients. And it's wonderful. You're the ones who are doing the research and just helping us out. But let me know if you want to send me information, emails, let us know how we can improve on our communication.
And we at the IWMF will do that too. That's part of the purpose of this, is to improve communication, let people know what's going on with P-crowd and impact. Exactly, because as you said before, there's no cost to it.
Correct.
So now
Yes.
we have to get bone marrow biopsies, but not long term. So there really aren't that many impediments. So come on, guys, how about it?
Yeah, and I would actually encourage everyone, talk to your family members. We would love to have every Waldenstrom patients sign up another person for Promise because familial Waldenstrom is very common, 30%. And if we can detect it early, we can make a difference. So that I would love to have, if everyone, while we're talking now, sign up on promisestudy.org, ask your brother, sister, any family member. I would love that.
Come on, guys, get busy. Now, another question on pCrowd. Have you started cellular or molecular analysis of samples yet from pCrowd study, or are you still only at the biobanking stage?
No, we did. So we actually just published 2 papers on our pCrowd samples, mainly in the myeloma area. And then now we're switching to everything, IgM and IgG. And the 2 papers were published last year, one of them in the Journal of Clinical Oncology, and I'm happy to send that information, where we found smoldering myeloma. If we took 214 patients with smoldering myeloma and tried to detect what causes progression to myeloma, we found 3 genomic alterations, 3 things in the DNA that were not discovered before that can really predict whether you will progress to myeloma or not, independent of the clinical markers. And the hope is that you do the same thing for Waldenstrom. We add that information. So you're not only looking at percentage of bone marrow cells, IgM, but you're also looking not just at your MYD88 or your CXCR4, but other factors.
So you still need more WMers to step forward so you have enough people to do the analysis on.
Yes, and especially IgM Mgus. I would love to understand why IgM Mgus progresses a little bit faster than IgG Mgus, right? Why it's a 1.5% instead of 1%. And we would love to understand why is that progression slightly higher.
Okay, here's another question for pCrowd. And this is true for me too. I work with a local oncologist. Are there any special shipping requirements or handling requirements for the blood samples so that have to be frozen or refrigerated or anything?
So we send you the box with the FedEx envelope in it, with the 3 tubes in it, with the instructions on how the phlebotomist will draw it. And basically they just draw it, put it in there. There's an ice pack already. There's the instructions on how to wrap it correctly and then ship it. You can FedEx it yourself, or you can give it to the local oncologist and they'll FedEx it. But we give you the FedEx envelope with the number and everything.
Sounds pretty easy. So basically I just go to my doctor and have them draw a couple extra vials of blood, toss it in the package, and either mail it myself or have them mail it for me.
Correct.
Making it so hard, Dr. Ghobrial. So are there any additional costs to participate in pCrowd or Promise or Impact?
No, no cost whatsoever. In fact, we know that it takes you time, especially now with COVID-19, to go to a Quest Diagnostics, to take time off, whether you're working or you're with family, to go to one place. And we are trying to figure out how to obtain funding so that we can actually compensate back. And we're hoping to compensate back people for their time and effort to go to Quest Diagnostic for that. And that should come up soon, hopefully.
Offhand, how many places does Quest have nationally?
Oh, a lot. And if you don't have a Quest near you, just let us know. They have a phlebotomy service that comes at home, and we can provide that one.
Okay. Another pCrowd question, somebody who is really paying attention. I think it's encouraging that you're coordinating with the Mayo Clinic on the blood analysis. How did that come about instead of this just being done at Dana-Farber?
So the mass spectrometry machine and all of the development was done at Mayo Clinic, and we like to think that we all work together rather than it's only at Dana-Farber. So the Stand Up to Cancer grant that we have right now for the Promise has actually 5 institutions. There's Johns Hopkins, there is Mayo Clinic, there's us, the Broad Institute, the School of Public Health. And the whole idea is that when we work together, we're much better off than working alone.
So you're sharing samples with those other researchers. That's all permitted under informed consent guidelines.
Correct. And it's not that, it's just that the Mayo Clinic is doing the mass spectrometry. That's already part of the big work that we're doing. And then we get the information and we call the patients back.
And how's your lab been coping with COVID-19?
Sorry, say that again?
But how has your lab been coping with COVID-19? It must be
Yeah,
difficult.
it has been very interesting. At first, of course, we shut down for 3 months, and then now we're back up and running. We're back to normal. Everyone is working very well. Again, we're all very well protected. PPE is in place and everything. But we learned a lot, and we've been really working. I mean, the whole idea of impact was, what can we do? What can we make as a difference now that we're in COVID-19 era? And how can we ask those questions for our patients?
You mentioned before that about 30% of people have a first-degree relative, but this question says, so if I'm the first one in my family with WM, I don't qualify for the PROMISE study, correct?
He or she does not qualify, but their sisters and brothers and the mom, son, and daughter do qualify. So let me just explain it. If you have the disease, Mgus or smoldering, you go on pCrowd. If your family member wants to screen, wants to look if they have Mgus or smoldering or amyloidosis, they go on PROMISE. They're sister trials. And to avoid the confusion, we're hoping to change our website so that if you click on it and you say, I have Mgus, it will redirect you, or it will tell you to go back to pCrowd and vice versa. But pCrowd and PROMISE are sister studies.
Okay. Speaking of sisters, could you just explain again what first-degree relative means?
Yeah, so mom, dad, sisters, brothers, son, daughter, first degree of from you, from the family member.
Not nieces, nephews, those are second degree.
No, yes.
Okay. Here's another question. I'm trying to understand the potential of the PROMISE study to help WM patients. Since multiple myeloma is so much more common than Waldenstrom's, if you recruit 30,000 subjects and hope for 3,000 positives, how many of those do you expect to have precursors of multiple myeloma versus precursors of Waldenstrom's?
Yeah, it's a great question. So first of all, we know that familial Waldenstrom is actually much more common than familial myeloma. So that may be an important question. And if more patients with Waldenstrom ask their family members to come in, we may be able to detect a lot of patients who are positive, and we find them early. And remember that you, as a Waldenstrom patient, your family members may get myeloma, CLL, amyloidosis. They may get other diseases and not specifically Waldenstrom.
Right. And do you think there will be enough Waldenstrom cases to power the study and be informative?
It all depends on the patients and everyone who's listening to this right now. If you increase the numbers, we will get the numbers.
Okay. And here's a more technical question. You mentioned informing the subjects if they are antibody positive for COVID-19 or have light chain changes suggested of amyloidosis. In pCrowd or PROMISE, are there other abnormalities, easy for me to say, for which you inform the subjects?
So pCrowd is research level for understanding the mechanism of progression. We are trying to now bring in a CLIA approved test so that we can tell you what's in the peripheral blood, what is the next generation sequencing. We are launching the information in aggregates because I cannot give it to the patients directly for now. So we're hoping that every 3 months we give back the information saying 100 patients with IgM Mgus have been sequenced. Here's the data of 100 patients and so on, until we have a CLIA approved test that I can give back to the patients.
You said the risk of progressing from Mgus to WM is about 1.5% per year, which is pretty low. If I have Mgus, how often should I get tested and what tests should I request?
Yeah, the usual is the first year, every 6 months, and then once a year thereafter. And the usual testing is, again, blood to make sure that you don't have anemia, the IgM level, the monoclonal protein, and light chains are the things that we routinely do.
But the Mgusers do not need bone marrow?
It's a good question. Once the M spike starts to increase, or once the IgM is high enough that we're starting to say, well, is this a smoldering Waldenstrom? Is this starting to show progression? Then we start thinking whether a bone marrow biopsy can help us understand the number of cells, the type of cells that they have. So they have MYD88, CXCR4, other things, mutations and changes that can occur there. We also do a lot of studies on something called the immune cells, and those are only in the bone marrow microenvironment right now, not in the peripheral blood, meaning, is your immune system dysregulated enough to cause progression? Is it part of the problem that you get recurrent infections, recurrent problems? People can have autoimmune diseases. So the cancer cells don't live alone. They live surrounded by their neighborhood, and we do a lot of neighborhood testing, basically, when we get a bone marrow biopsy.
Okay, great. Now here's some general questions about early WM. You showed data from the multiple myeloma research. How far away are you from having similar data from WM, and how many more WM participants do you need?
Yeah, so again, the numbers are important to get, as you said, the statistical power. So once we have 200, 300 Waldenstrom cases, then we start sequencing. We're right now sequencing 500 more Mgus and smoldering myeloma because we have the numbers. Mm-hmm. I would love to encourage every patient with Waldenstrom to think about that and help us, launch the next 500 asymptomatic Waldenstrom and IgM Mgus study to really make a difference.
Okay. And another general question, if my WM is smoldering, is there anything I can do to prevent it from spreading? Are there any medications, supplements, or lifestyle changes that would be helpful?
Yeah, so part of the CPOP clinic, we of course have therapeutic trials for high-risk smoldering myeloma because that's very aggressive. We are going to do studies also for high-risk Waldenstrom, smoldering Waldenstrom, but we do have a lot of studies that we're launching soon for the low-risk smoldering, which are based on exercise, health habits, as well as we're opening a study soon of Metformin. Metformin is a diabetes drug, a drug that we use to prevent high blood sugars. And we've seen that it can actually change the way the cancer cells take up sugar, basically the metabolism. So we will be launching soon a study of Metformin versus placebo to see if that prevents progression in the very early smoldering in the low Mgus. So not very low Mgus, of course, but in people who are almost intermediate between the very high risk and the low risk to see if it can prevent progression.
Is that in multiple myeloma or in WM?
That will be for any asymptomatic. I can double check. Catherine Marinek, who's the principal investigator, I'll check with her what's her inclusion criteria for that, but it should be open for everyone.
Okay, here's another question. Can people like me with smoldering WM and steady IgM counts stay that way for years, or will it always progress to the point of treatment is needed? I'm 77 years old.
Yeah, so it's a great question. We know that some people progress very rapidly and some people don't progress at all. And we don't know why. Is it because your cancer cells acquire something else, what we call secondary hits, or is it that your immune system is so good in preventing the cancer cells from growing? And these are the two things that we're looking at, of course.
Okay, and another, is Imbruvica effective to, one, treat Mgus symptoms and to prevent progression of Mgus to WM?
We don't know the answer to that. We need clinical trials before we start treatment. Again, I'll repeat it. I am not treating asymptomatic Waldenstrom. I will not tell you to go see your doctor and get treated for asymptomatic Waldenstrom unless we have clinical trials to prove benefit that early treatment makes a difference. Please do not go get treated for asymptomatic Waldenstrom.
Here's one last question actually about familial WM. Regarding familial WM, most of us don't have that. Can you talk about the idea of relative risk and absolute risk for our kids? This is a long question. From what Doctors Kyle and Gertz have said at previous ed forums, while the relative risk may be several times higher for our kids, the absolute risk is low. In fact, I remember Dr. Gertz saying something like, we should just tell our kids to get a total protein test at age 50, and then every 5 years after. Is that what you'd advise if there isn't any familial disease?
So it's a great question. That's why we're doing the PROMISE study, right? You do not know, you're saying I don't have familial disease, but you didn't really screen the whole family to get that answer. So you don't actually have the answer. So the best way to do that is do the research. The PROMISE study will help us to understand what is the rate of positivity in your own family members if you have Waldenstrom. And by doing that study, we will understand better what is the true percentage of positivity in the cohort.
Okay. Is there any last thoughts you want to leave with people listening today?
Yeah, I think, just like saying I trained with Bob Kyle and I have a long history, I had my very first job was in Waldenstrom. I was recruited at Dana-Farber to work in Waldenstrom. My very first grant was actually a Waldenstrom grant. And it's a special thing for me. And I feel that I wanted to refocus my lab and my research and my clinical trials on asymptomatic disease, Mgus and smoldering. And I'd love to have that power of patience that Waldenstrom has, that sense of we are all going to solve this because it's a rare disease, but we're not rare. And I love that sense that everyone has. And I'd love you to help us get the research done for asymptomatic disease.
We will certainly have I bet you've recruited a whole bunch of people today, and we'll make sure that we publicize and continue to publicize the excellent work that you're doing. So thanks for your participation in today's program and for answering our questions. And I want to thank the sponsors of our program. The title sponsors are Beijing, Janssen Biotech, and Pharmacyclics, and also X4, Selectar Bioscience, and Treadway Foundation. And I want to remind the rest of you that are listening, there are 2 upcoming seminars that you should put on your calendars. We'll send out a notice to you, but on November 10th, Dr. Edward Libby from the Seattle Cancer Care Alliance will run a webinar on understanding your blood and bone marrow test results. And if you participate with Dr. Ghobrial, you may need to understand your bone marrow more. And on January 21st, Nina Kennedy from LLS will do Why Clinical Trials Matter and How to Find the Right One. And clinical trials, as Dr. Ghobrial suggested, are critical to us reaching our vision of a world without WM. So thank you all for participating, and thank you, Dr. Ghobrial. You were wonderful.
Thank you, Carl. I appreciate it.